The views expressed on this podcast are those of its host and its host alone. The purpose of this podcast is for education and entertainment, and not to diagnose or treat any health condition whatsoever. Please talk to your doctor if you have any concerns about your health.
Welcome to Crash Cart. This is a well-perfused production. Welcome to another exciting episode of Crash Cart. Today, we are delighted to be discussing the interesting topic of lipidology and current lipid management with our burgeoning lipid expert, Dr. Nisarg Ray. How are you doing, Nisarg?
Doing good. Thanks for having me.
You excited to be here?
Excited and looking forward to our discussion.
We're excited to have you. So we got plenty of questions today, and Dr. Faz Salat is going to take us through them.
Excellent. Thank you again, Sarg, for being here. So first question is, give us the big picture. Why do we push LDL so hard? Why is it something we hear about so often? Why do lipids still matter? And in the wise words of the rap song LP, how low can you go?
So how low is too low? That's a good question to start with. So the ASCVD risk it tracks linearly with the cumulative LDL exposure. So basically, total plaque burden that you accumulate over the lifetime is directly proportional to your cumulative LDL exposure throughout your life. And so that kind of emphasizes upon the lifelong healthy eating habits. So my answer would be lower is better and earlier is better. In secondary prevention, the US guidelines basically aim for greater than 50% LDL reduction. What the European guidelines go is even further, and they target very high risk for patients less than 55 milligrams per deciliter reduction in those events. Yes.
So to summarize, what you're saying is the longer someone is exposed to a high level of LDL, and the definition of high would be what? Greater than 70?
70.
Okay, got it. So the longer we're exposed to that, the more likely we are to have actual plaque buildup.
Correct.
Got it. And second question was the greater than 50% reduction. Over what time period is that? Is that from one lipid panel measurement to the next?
Correct. So greater than 50% reduction. So for example, if you start someone on statin therapy, usually follow up with follow-up lipid panel in 4 to 12 weeks. So that would be an appropriate time scale to revisit and expect the 50% reduction.
It's almost as if it's like tobacco and smoking pack years a little bit in the way that you think about total cumulative exposure to LDL. People have often asked me, well, then why don't we try to get everyone below 70 if we're starting to accumulate exposure beyond that point? I often answer because the goal is to die with some plaque and not from some plaque. And if we can maintain our lipid management to around that range or below that range for very high risk people, that's really the goal, is to limit that exposure in that population.
And frankly, I remember learning as early as med school that it is to a certain degree normal for every human being to have some degree of plaque upon death. So even someone relatively healthy will have some amount. So you bring up a good point, Noah.
Thanks, Nisarg, for all this insight so far. The big million-dollar question we have is, how should residents actually decide who needs drug therapy?
So as we were basically taught in the med school, we start with the pool cohort equation, or colloquially known as ASCVD risk calculator. That's what we Google on MD Calc. It's for basically adults 40 to 75. We personalize this with the risk enhancers, which basically involves like a family history of premature ASCVD, like heart attacks, people passing away before the age of 50, requiring early revascularization, or LDL-C greater than 160, CKD, inflammatory disease, high Lp(a), which we can touch upon more later, and elevated apoB levels. These all factor in for the decision making regarding whom to start on drug therapy and when to start them on drug therapy. And if the decision is murky, if the ASCVD risk score, the PCA risk score is borderline intermediate risk, less than 7.5, sometimes we order coronary artery calcium score, which is like the tiebreaker we use. CAC 0 often buys time, so except if the patient smokes, has diabetes, or have strong premature family history, we go ahead and start them on medical therapy. And if they have CSE 1 to 99, they also it favors more on the statin initiation of statin therapy. And having CSE of greater than 100 or like upwards of 75th percentile, that also is an indication to start a statin therapy.
No, thanks for walking us through that. I often get questioned about this coronary calcium score from my patients. So it sounds like if they already have high ASCVD score, they should be started on statin. But if they have some doubts whether they meet the criteria or not, then they could qualify for this test.
Correct.
It is important to note that the real value is in the negative predictive value with the coronary artery calcium score. A score of 0 is associated with very low risk of cardiac events in the ensuing year. What the coronary calcium score does not tell you about, however, is immature plaque that is burgeoning and is not quite calcified yet, and those are the ones that are prone to rupture and cause acute myocardial infarctions. So when patients say, well, yeah, my ASCVD risk score is high, but my calcium score was pretty low, if they have any calcium at all, it still doesn't tell you about what immature plaque they may have that's putting them at risk.
And that makes sense physiologically. If we call it a calcium score, then we're implying that this is a plaque that has matured to now be essentially calcified. Whereas, as Noah mentioned, it will by name just not catch something that hasn't calcified yet and is by definition immature.
Correct. And that brings up the old point that I brought up as well. It's like the cumulative exposure over the lifetime that affects those risk scores. Some of them could be caught up on the CAC score, as Noah was mentioning, if they're calcified, but you're definitely at risk as well, considering if you have other comorbidities going on.
Yeah, makes sense. And I think not only is there one of the risk factors is if there's a family history of anybody with hypercholesterolemia, but I imagine there are certain ethnic groups or racial backgrounds that are predisposed. For example, South Asian heritage plays a large role in various risk factors for accumulation of LDL. Have you found that in any of your research, or is it mainly based off of which folks sporadically may have family history of high LDL?
Not that I was reading through the guidelines, it didn't catch my attention, but I agree. The South Asian populations is one of the highest people who have this higher ASCVD risk scores compared to other ethnic populations.
Yes. Considering I'm South Asian, I was asking for myself. Thank you.
So what kind of tools do we have to manage this LDL? We have a patient, we know their LDL is 150, they're actively smoking, maybe they've had a heart attack before in an outside system. I need to get this guy's LDL down today. How do I manage that?
So in our toolbox, starting with the most common drug we have, statins, which basically acts on the cholesterol synthesis pathway. The next one in our toolbox is ezetimibe, or brand name Zetia. It basically affects the cholesterol absorption in the intestine at the brush border. The next one we use is PCSK9 inhibitors. These are monoclonal antibodies that, as the name suggests, it acts on the PCSK9 proteins. Basically, all in all, affects the LDL receptor presentation at the liver cells. And another drug that affects a similar pathway, it's called inclisiran. It's a small interfering RNA inhibitor that affects the PCSK9 protein translation that leads to downstream effects similar to as PCSK9 inhibitors. And lastly, we have one more drug. It's called bempedoic acid, brand name Nexletol. It also works on the cholesterol synthesis, but earlier on in the pathway compared to statins.
So if we have all these newer drugs, and my understanding is that statins are pretty old, why are we still using them?
I think the reasoning behind statins being the more widely used medication is multifactorial, I think. It's definitely a widely available drug covered by a lot of insurance providers. But there's also a robust clinical data behind their efficacy as well that provides them more head forward compared to other drugs in selecting which drugs to start people on for LDL lowering.
And then based on my experience in the clinic, I have always started with statin, but sometimes like 2 weeks later, patient messages me that, okay, I'm experiencing myalgias. So in that case, I would stop the statin. What would be the next step in this like escalation ladder that I could consider for my patients?
So that's a very good question because it touches upon two important points regarding statin intolerance and what's the next step in the ladder. We can talk about statin intolerance further later on, but for the discussion now, the next step in the ladder would be starting on ezetimibe or Zetia. This is also one of the very widely available drugs covered by insurance as well, and also one of the drugs that in this ladder that have least side effects as well. Because of its mechanism and how it works. Even though it has lesser efficacy in lowering the LDL, we expect about 20-25% LDL lowering compared to 50% in the high intensity statins. But that would be the next step after that.
So I've started a patient on a statin. I've started him on ezetimibe, and he's still not to goal. What am I supposed to do?
I'm not sure about your patients, Noah. But if they're still above the goal or very high risk, we usually add a PCSK9 inhibitor. Some of the ones that are available are evolocumab, the brand name is Repatha, or aliricumab, the brand name is Praluent. They typically deliver another 60% LDL reduction on top of statin and Zetia, and they reduce heart events within like 2 to 3 years. And so many patients would also bring this up regarding LDL lowering as well, regarding the cognitive safety, if the how low is too low LDL. The cognitive safety at very low LDL has held up in the Ebbinghaus trial, and long-term extensions have been okay as well.
So there is, to this point, no danger in being too low because these PCSK9 inhibitors are dosed every 2 weeks, and they get people's LDLs down to, I think the lowest I've seen is like 10. Is that similar to what you guys have seen?
I haven't seen that low yet, but I agree. The research hasn't shown any cognitive effects regarding low LDL levels.
And so the Repatha and Praluent are both every 2 weeks. What about this medicine I keep hearing about called inclisiran?
That's a very good point you bring up. Inclisiran is a small interfering RNA medication. It's good for patients who are not very medication adherent or not very compliant because it's only twice a year medication. You give one injection every 6 months compared to Repatha or Praluent. It has similar lowering efficacy as LDL with Repatha and Praluent, but it's less available, and there's not much clinical trial data that has shown rephrase that, sorry.
I see what you're saying. So not too much clinical trial data on the heart outcomes. We know that it lowers LDL, but then again, so does niacin, right?
Agreed.
So we still have to figure out, well, does this prevent MIs and cardiovascular death? And then the forgotten stepchild of lipid-lowering therapy, bempedoic acid. It's new, it's fun, but I don't find myself reaching for it a lot. Tell me why I should reach for it more often.
So bempedoic acid, I've seen it more used in people who are statin intolerant, who cannot sustain a statin therapy because of like side effects like myopathy. It's bempedoic acid. It is a brand named Nexletol. It's another good medication. It cuts down LDL by 70 to 25%, and the clear trial has shown pretty good outcomes with that medication, but not very widely used, except when people are statin intolerant or people who have LDL, like your patients who do not budge from lowering.
Oh, it's certainly tough. And one other thing that's interesting to note about some of these medicines is it can also be somewhat diet dependent. Someone who has a very cholesterol high diet, who's started on ezetimibe, which prevents absorption of dietary cholesterol, would expect to see greater lipid lowering therapies than somebody who has next to no cholesterol in their diet. But overall, does dietary cholesterol make up that much of a difference in terms of patients' overall LDL? Like a patient says to you, Doc, I don't need a statin, I'm just going to change up my diet. How often is that effective?
No, that's a great question, Noah. I always wonder that whenever I'm consulting patients in the clinic. And whenever I tell them like, hey, we need to start a statin for you, they always tell me, can I do some dietary modification first? and see how my like lipid reacts to it before I go for this medication that I might be bound to for life. I think that's like one of the biggest fears. And in my clinic, I see some pretty healthy patients. And when this is one medication that they're told to take for life, it kind of scares them that, okay, now I'm becoming this guy who's becoming like dependent on medications, and I have to take this every single day to maintain my cholesterol. So I always I don't know how clinically supported this is, but I always tell them, let's try it for 3 months. Let's see if your diet brings your LDL down to the optimal range. And if it does, then let's hold off on the statin for some time.
Yeah, I agree with you. I also think that seeing an elevated LDL can be a strong motivating factor for patients. And so I usually counsel them like, yeah, let's use this as an opportunity to take control of our health and increase our exercise and improve our diet to a more healthful eating pattern. But I do still counsel them that much of LDL is genetic so that they don't become discouraged if all of their efforts still result in them needing to be on some lipid lowering therapy at some point. So we talked about secondary prevention, in which someone has already had a heart attack of some kind, and they should be started on a high-intensity statin out of all of the agents, not just for the lipid lowering, but for the anti-inflammatory benefits as well. But what about our primary prevention patients, our patients who haven't had an event yet? You know, let's say I have a 50-year-old male who comes in with an LDL of 165. I plug his information into one of these risk calculators, and I find out that he needs to be on lipid lowering therapy. How do I do that?
Exactly. So for my patients, if they're between the age of 40 75, without any diabetes or any other ASCVD risk factors, I use the PC equation as you did. Look for any risk enhancers, as we discussed before, like family history and their LDL. And as you mentioned, the LDL was about 160 for this patient. So I think the first step would be to start them on a high-intensity statin, which is basically atorvastatin or Lipitor, 40 to 80 milligrams once daily, or rosuvastatin, 20 to 40 milligrams, also known as Crestor, once daily, and target our LDL levels of less than 50% at our next checkup, which I would repeat usually in like 4 to 12 weeks.
So for that patient, you would think less than 80. That's it. What if the patient says to you, you know what, I read a lot of bad things about those statins. I'll take other medicines, but I don't want that one. Does it matter that much, or we just don't know, or what options do we have?
Yeah, so I would also touch upon the lifestyle management things, changes in diet, more exercise, and also do some counseling and anything that basically gets them over to that LDL goal. May that include bempedoic acid, ezetimibe, or even a PCSK9, depending on how the risk factors are and how urgent is that the goal is to be reached.
You know, it appears that this is much more complicated than we initially thought when starting this podcast, so I think we need a part 2 if everyone's in agreement. Join us next time for part 2 of Lipidology Madness.